Okay, let me see my participants. There we go. All right. Welcome everyone to another episode of A Conversations. Today we are joined with Dr. Janet Legare, who is a pediatrician and director of Bone Dysplasia Clinic at the University of Wisconsin-Madison. We are so excited to have her with us today. Dr. Legare, you have been someone that a lot of our audience or community has been eagerly waiting for us to have a conversation with. So to just get started and everything, well, first, thank you for joining us. But to get started, can you sort of just tell us sort of about yourself and what your role is and how you kind of sort of got interested in specializing in bone dysplasias?
So first of all, thank you for having me, Chandler. I'm looking forward to the next hour where we can just kind of chat and answer questions and go from there. So I have always been really interested in how the body works. And I was interested in how, biomechanics and things. And I actually, after I went to medical school, I did residencies in both pediatrics and pediatric physical medicine and rehabilitation. So, and I have a background in genetics. And so in college, I did genetics. I worked in human genetics. I worked at the Weissman Center at the University of Wisconsin. I met 𝘾𝙊𝙉𝙍𝙍 at that time. And when my husband and I were ready to come back to Wisconsin, I basically did an apprenticeship with Dr. 𝘾𝙊𝙉𝙍 for 3 to 5 years. And really became a specialist in bone dysplasia. I worked with him somewhat in college as well for a very short amount of time. But I really enjoy working with people that have different types of needs. Mm-hmm. I really consider myself a kind of a primary doctor in the sense that I look at the whole picture, but for a very select group of diagnoses. So I really like to look at the whole person. Mm-hmm. And I really enjoy visual learning. I really enjoy interacting with patients. I enjoy interacting with families. I really like seeing patients across the entire lifespan. So we see prenatal, we see babies, we see people throughout their lifespan, even into adulthood. So it's really worked out quite well. And then I've been directing the Midwest Regional Bone Dysplasia Clinic since 2015. So.
Very cool. One thing I will say just personally is something that even my mom and I have talked about, and I've talked about with other adults my age, is we always wish like someone, because you have turned into, I feel like, the go-to given your background. And so I always say I wish like I had a Dr. Legare when I was, a young, new, or my mom says, we wish we had someone like Dr. Legare, when I was younger. So, kind of going into that, this is a conversation. So we know you see many with different various bone dysplasias, but kind of to focus just for ease on achondroplasia, what is something families can expect when they first come to the clinic to see you and to visit your practice? What would a typical kind of first appointment be like, assuming this is their first kind of get to know what they can about achondroplasia?
Well, I just finished one of these appointments because we added it on. When there is a new baby born or a new family with a new diagnosis, we usually add them on and get them in within, definitely within a couple months. sometimes within a week or two. So it really depends on the diagnosis, but in general, what we do when we see you is gather all of the medical information, including hospital records, x-rays. Sorry, that's my dog.
Good.
Hospital records, x-rays, growth charts. And then, you know, I'm going to spend time going over the history with you. I'm going to do a very complete physical exam. I'm going to go over the x-rays with you, show you what I'm looking at on the x-rays. And then the very first visit, I spend a good 30 minutes, if not a bit longer, really just kind of teaching the family about their new diagnosis, because nobody will ever advocate for their child like parents will. And so, you know, we have a lot of specialists, and we're very fortunate that there's a community of people, even if it's across the country, you know, and it's not all in the same city, but that know about these different diagnoses. But parents really need to understand why we're looking for what we are. And I'll be honest, all skeletal dysplasias are not the same. And I think we all know that. But many people say, oh, I know achondroplasia. So they think they know everything, including SCDC and things that are very, very different. So I think we spend a lot of time teaching that first visit. The first visit is actually 2 hours.
Wow.
The second and subsequent visits can range anywhere from an hour to an hour and a half. It really depends on what is needed at that visit.
So, you know, you said, you know, you try to get them in as soon as they can, and it might take a few months and everything. But what is it like if you have this? How, or I guess, you know, what is the best advice or course of action you would give families who maybe can't come to see you, or who are, you know, maybe out of the country, you know, outside of the US, and are maybe in a territory that's unfamiliar with skeletal dysplasia as a whole? Are there any ways that, you know, or tips or anything that you kind of provide to those families who maybe can't come and see you, or what, or even pediatricians? Do you have any that kind of like reach out to learn more from you? And like,
so we have some general, we have a general packet of information that we send. And so when somebody is referred, the first thing that Peggy Modaf does, and she's the genetic counselor who's really the backbone of the clinic, she calls those families. So we make contact with them, you know, almost immediately. And sometimes those appointments aren't for a couple months because we have to get x-rays, we need to get a sleep study, we need to get other things done, or they live a couple states away. We send a packet of information for achondroplasia, for example, for new parents that includes some articles and some generalized teaching information. And then we go over it again when they come. We are happy to talk with pediatricians that reach out. We send them information as well. We frequently will talk to physical therapists, because if somebody is sent to physical therapy as a baby, we don't want them being put in a sitting position. So we will talk to physical therapists as well. We get quite a few people who contact us via email or track us down, and we always respond. I now have a license in 6 states for the main reason that with telemedicine, if you're licensed in the other state, then you can provide services there. So like, for instance, I can do a video visit with somebody in Missouri. You know, at the beginning of the pandemic, they got rid of all the restrictions, and we were able to do video visits with a lot of people in a lot of different states. And we realized that that was really, really beneficial for a lot of our patients. And so we do video visits, and, you know, we do what we can to try to get people the services they need. I have also somebody reach out to us from Brazil, and provided information in Sao Paulo, the big clinic there. So we do what we can.
I know you kind of discussed, when they have, or when you have your first general appointment, you talk about, what the sleep study said or x-rays or anything. But say if we like had a family on right now who's new and hasn't had that, what are the early signs and general concerns that parents should look out for, for their child with achondroplasia? Obviously, foramen magnum stenosis is a big one, but just, for a new family who may watch this, what are early signs and kind of symptoms you would recommend that they
You're talking about like outward clinical things that I would see if you have had. So, as many of you know, the foramen magnum, that is the opening at the base of the brain. That is smaller in achondroplasia, but the brain stem and the upper spinal cord are normal size. So, so what we do is we do an MRI to look at the picture, and then we do a sleep study to see how is that area functioning. But other things that you might see are your baby's not feeding well. Your baby's wanting to, arch backwards and really sleep in a C position. The other thing that can be pretty concerning is what we call a fixed torticollis. So instead of, sometimes babies will tilt their head a little bit. And so that's fine if they sometimes tilt it the other way or go both directions. But let's say they tilt their head at exactly the same amount all the time and it doesn't move. That would make me concerned that they're trying to keep things open in the back as well. So things to watch for, if you haven't had the studies, are going to be not feeding very well, coughing or choking or gagging with feeding, having really having a fixed head position at a tilt. Other things would be the muscles are really loose and floppy. We expect them to be somewhat loose and floppy with all babies with achondroplasia, but if they're significantly loose and floppy, that can be a concern. Or really, if there's any differences or asymmetries between one side or the other. So we should see no asymmetries in babies until like 2.5, when they might develop handedness. If you're saying that, oh, the right side just seems to be stronger than the left side, or the left side seems to be stronger than the right side, those are things that would make me concerned.
Mm-hmm.
Or, having little pauses in their breathing, or, just episodes where they're less alert than you would think.
Mm-hmm. One thing that we know is a big thing right now is Voxzogo, and there's a lot of research surrounding or going on for other potential maybe treatment options for I can't even say my own diagnosis, for achondroplasia in the pipeline. Has that obviously changed any kind of course of actions when new families come in, or families you've seen for years now? How would you approach that when families come in wanting to seek more information about Voxzogo, or maybe even getting involved in a clinical trial if they want to, just since we know that's a big thing right now? How would a family go about that? Or how would you decide what, I guess, the best course of action is?
So I think that in general, new parents ask about, most parents have done some research. Most parents are actually aware of clinical trials and different stuff on the market. It does make it interesting because, as we know, Voxzogo is approved for 5 and up in this country, but it's approved for 2 and up in Europe, 0 and up in Japan, and possibly 0 and up in Australia. That announcement was coming pretty soon. So it definitely changes the conversation a bit. As far as how I have the conversation with families, I think unfortunately, the clinical trials have become divisive in the little people community. And one thing that I tell all of my patients, and I make time for this regardless of if they have average stature parents, little parents, whatever, is that I say this is a safe space. You can ask me whatever you want, however you want. You can comment whatever you want, and I will answer, and we can have a conversation. So I make that a point with all of my patients with achondroplasia, regardless of, if they don't bring it up, I bring that up at the end. And then sometimes it kind of opens up floodgates and there's a lot of questions or a lot of comments. Many times, we reach out to the families when we're scheduling them, and before they come, they'll tell us, look, I want to talk about Voxzogo, or I want to talk about clinical trials because my child isn't old enough for Voxzogo, or do you think it's worth, trying to get Voxzogo? So, but I do bring it up.
Yeah. We did get one. My son in the chat, someone says, my son was first diagnosed with achondroplasia at their 9-month well visit from his pediatrician. That life-changing moment is seared into my memory forever. She, the pediatrician, handed me a Xerox copy of a medical encyclopedia article on achondroplasia and arranged a consult with the geneticist, gave me a hug, and then saw me out of the clinic. How do you deliver the news of a major diagnosis to parents? And I guess that could go with any, not just an achondroplasia diagnosis.
I think that's a really thoughtful question. I give major diagnoses to parents every day. Today, I told a family that their child had cerebral palsy. So I think so I can tell you that every diagnosis is a bit different. What I emphasize is that what we name this or putting a label on things doesn't change who your child is. It just helps us put a name on it so that you don't have to explain everything to everybody every time. And it helps us know, what are we expecting? What are we anticipating in the future? So I don't think that I would hand a Xerox copy of a medical encyclopedia. I think what I would do likely is read up on the diagnosis, kind of explain what it is, take some time, sit there, listen with you, make sure I'm sitting, talking with you about the diagnosis. What I do when I give big diagnoses is I always call the family back a week later. And just to say, hey, do you have any questions? Has anything come up? What can I answer for you? So, I don't know if any way is perfect. Some ways are definitely better than others. But I think the main thing to stress is that, especially with achondroplasia and a lot of these skeletal dysplasias, it doesn't change a lot of your thinking skills. It doesn't change anything that you can do with your life. Yes, your bones are affected, but the rest of your life, you can still do all of these things. And many times if I'm working with a neurodevelopmental diagnosis, okay, this is their medical diagnosis, but how much disability they have is really up to how the world around them works with them, And so they're still, first and foremost, you have a 9-month-old boy who's beautiful, yes, he happens to have achondroplasia. In my opinion, that's a blessing.
I always say, I always say, when I think about, just for me personally, when I think of other genetic conditions or, whatever, I always say, I feel like achondroplasia was like the gold star to, get. And, that's just me. I always say I'm so fortunate, uh, that's, what I was given, with knowing how much more severe a lot of other different dysplasias are or can be. I was gonna say, I remember when I was diagnosed, but I don't remember when I was diagnosed. But I remember having the conversations with my mom about when I was diagnosed. I was one that was diagnosed at birth, and it was our pediatrician that and that was in 93. And fortunately, we were very fortunate to have or my parents were very fortunate to have a pediatrician who was very much like, I don't know anything about achondroplasia, but we're going to figure this out together. And it was one of those things where my mom says before they took me home from the hospital, like left with, I think, again, it was 93. So they left with whatever folders of papers and research. And now, we're so fortunate today that you can just research on your phone, right in the palm of your hand. But that kind of was like leading me to want to ask, is it different when you I'm trying to word this correctly, but when you are like, how often are you diagnosing children with achondroplasia, I guess, after birth? Just because knowing, like, we're involved in a lot of these online parent boards, and we still see today that some children aren't diagnosed until after birth. Is there a difference in kind of how to approach that first appointment when a baby, I guess, is about to be born with achondroplasia versus you don't know, the parents don't know yet of the child's diagnosis after birth? I don't know if I asked that correctly, but I hope I made sense.
I think you did ask it correctly. To answer your question, about 20% of children with achondroplasia are still diagnosed after 1 month of age. And so
I didn't know that.
it's not that uncommon. Between 35 and 40% are diagnosed prenatally now. And then many in the first 24 hours of life, and the rest in the first month of life. But it's still notable that a lot are diagnosed later. So I do think that how we approach that first appointment is different.
Yeah.
The way I would approach the first appointment may be similar to how I would approach a prenatal appointment. I want to give a lot of information, but also I want to spend time listening and not just talking. And I think sometimes the best thing we can say as a physician is, I don't know, but I will find out. So we don't have all the answers. The nice thing is that achondroplasia is the skeletal dysplasia with the most known about it. So we have many answers for this one, but we still don't have all of them. So I think, we would approach it differently. And the other thing is that the recommendations will be different depending on when the child is diagnosed. If you have a child diagnosed over 1, your recommendations may be very different than if you're diagnosing that child at 1 month.
I'm pulling up to see what other questions I had, and I wanted to ask, our audience one more time if they had any other questions. But I guess I want to say I've kind of asked all of mine. But is there anything, maybe that I should have brought up, but that we didn't bring up, that any advice or anything you would give to new parents, or even just caregivers in general, grandparents or anything of, children with achondroplasia or bone dysplasia? Because we're definitely open to, discussing all skeletal dysplasias and bone dysplasias. But is there just in general, just any advice or the best course of action that, you would give a new family or just a family in general about, just treating their child's condition or not treating it or anything?
Well, I think as far as treating or not treating, most of our skeletal dysplasias,
Or I guess I
and
should have said managing, like,
I was
managing
gonna say,
care.
except for metabolic, really don't
Yeah,
have
managing the care is what I
treatment.
meant. Yeah.
As far as managing, I really think I see a lot of people who they always say, I just love coming here because somebody looks at the whole picture and I can get all of my questions answered. I don't have to explain everything to you. And, I either get, I know what to look for in the next year, or I know what our next step is. So that doesn't have to be a geneticist. Yeah, that can be a pediatrician who's extremely well informed. That can be an orthopedic who's very interested in the whole picture, like Dr. White or Dr.
Mhm.
Hornschmeyer. And so I think what's important is to just find somebody who is really knowledgeable about the diagnosis. That could be an ENT, that could be a neurologist, that could be wherever, whomever. But I think the most important is to know that this doesn't change who your child is. You need to still treat them as a normal
Mhm.
child. You may have a 4-month-old boy with achondroplasia. Well, he's first and foremost a 4-month-old boy. Achondroplasia, yes, his bones grow differently. But first and foremost, he is a 4-month-old boy.
Mhm.
So the other thing is that, and I hate to bring this up, but I work with people with a lot of different genetic diagnoses, some much more significant than others. And I do think that there is a grieving process,
Yeah.
in parents who are average stature. If they have a child with a skeletal dysplasia, they're grieving what they thought their child was going to be like. And that's still grief. That's still
Yeah.
loss. It doesn't mean that it's not absolutely wonderful that they're going to have a wonderful life with their son or their daughter. And it's not, and so many parents will feel bad about that, but it's nothing to feel bad
I was
about.
literally
It's
just having that
different.
conversation with someone this week, and that's what they were. It was actually a geneticist, and that's exactly what she was saying. And it's something that she, any patients that she sees with any sort of, new genetic diagnosis or rare genetic diagnosis, it's kind of one of the first things that they talk about. And she's like, there's no shame in feeling that way or anything. And so, yeah,
Yeah, it's really it doesn't mean that you don't love your child and
right.
love what your life is going, the differences that it's going to be, but it's you're grieving the loss of that idea.
So we did get another one. Or another question. Do you think pediatricians have a role to play in encouraging new parents to be advocates for their newly diagnosed child? Issues like enrollment in trials or appealing insurance companies or finding a more skilled provider?
Yes. Can I just answer it like that? No. I actually was a pediatrician for 14 years. And so, I don't know about the clinical trials part. I think that, your pediatrician should be, I think your pediatrician should be an advocate for you,
Mhm.
to get you to the most skilled provider, to help you find information so that you guys can learn together and to get you to the appropriate places, that if you're interested in those clinical trials. But to be honest, as a new parent, you're overwhelmed with these diagnoses. So the pediatrician can be in the background doing clinicaltrials.gov,
Mhm.
searching for things and finding out where is the best place for me to send my patient to get the best information. I think that I always tell parents that nobody will advocate for your child like you will.
Mhm.
I mean, I can advocate for your child. I can do a lot of things, but nobody will ever advocate for them as much as you will.
Mhm.
So I think that, as far as I think that pediatricians should be advocating for those things for you and helping you kind of navigate the system if
Mhm.
he or she can.
Yeah.
Whether or not they should encourage you to do all of that as a parent, I don't think you should have to do that all as a parent without the backup of your pediatrician, if that makes sense.
Yeah. No,
I think
I like
you need both.
No, I like that a lot. I feel like you're the first healthcare provider, or just in general physician I've heard that ever to ever really to say that, parents are the biggest advocates for their, you would think it's like just in general common knowledge, but I love, just actually hearing it be said out loud. That's just, I think, very moving. And I'm sure a lot of our parents, would definitely agree to that. I agree to that. And I now take care of my own whatever, but my mom is definitely, when it comes to my health concerns, is still knows more than I do, I think, about all of my things, even though I'm very much, able to take care of my own health concerns and issues, but she's still.
Well, one thing I want to kind of mention, because I also see, I see a lot of families where parents are little and their children are little. And it is very different being a little person versus caring and parenting a little person.
Yeah.
So to be quite honest, a lot of our discussions are not that different, because we still go through the whole process of why we see what we do, what we're going to look for, what we have to do for the school. And so, the people don't remember what happened to them when they were 4. Think about it. You don't.
Yeah.
And so I do get that question a lot as well. Do you treat little parents different than average stature parents? And the answer is no.
Yeah, that's a really, a great approach. It's, because they're just
first and foremost
both just parents. Like they're just parents. Like they're first and foremost, they're just parents to a child. So it's not like they're any different, than any other parent off the street. So that's a really good point to make. But I want to say that's it, unless anyone has any more live questions for Dr. Legare, feel free to submit. But, we really kind of wanted to just, get the overall kind of, pediatric or pediatrician's almost approach to achondroplasia or skeletal dysplasia, bone dysplasia in general, since you are someone who's first and foremost the first person families are coming to see post diagnosis or pre-diagnosis even. And so hopefully, our watchers, our viewers gain a lot from this. But thank you for joining Growing Stronger in this. And we would definitely love to have you back for maybe, we could come up with different topics to discuss for future episodes. But yeah, thank you so much for joining us this evening.
Yeah.
Awesome.
Have a good evening, guys, and thank you for changing the time.
Absolutely. Anytime. Thank you. All right. Bye.